Today I'm just going to cover four cases, adolescent cases, and we'll just discuss the management options and take each one of your perspective. Meanwhile, I think the dermatologists and our endocrinologists will try definitely to cover all the questions that are raised by the scientific committee. Although I am not I'm not a I'm a gynecologist. Okay, so the middle one was treated by me some 7 8 years back. She's really lean, and she had come to me with severe anemia and severe abnormal uterine bleeding, treated with me, and she's now on long term OC pills. So after 7 8 years, she got two of her sisters. The right side, the left side one, who's a little overweight, she is 21 years old. Her BMI is 29.4. She has no acne, mild hirsutism. She gets scanty menses in 3 to 4 months. That is why they ignored her for all these years. The youngest one is 17 year, the one to the extreme left. She's just 17. She's very thin. Her BMI is 17. She has acne, hirsute. She gets prolonged irregular menses. She gets for 20, 30 days at a time and once in 2 to 3 months. And that is why she was forced to get both her sisters. So this is the pictures. Both of them have typical ovaries on ultrasound with a volume of more than 10, 12. The lean one has acne. She has significant hirsutism. She has no acanthosis. The overweight one has no acne. She has barely the hirsutes. It's just like villous thin, fine hair on her face. She has skin stria, and she has very severe acanthosis. Now, before we go to managing and investigating these patients, I would like to ask Dr. Gulre, she's our dermat. Do you think how can we differentiate between the acne of puberty, which is very normal, and something which is much more sinister, like in PCOS or conditions of severe hyperandrogenism? And second, is there a difference between people who get acne more on their back and arms, like I've shown in this picture, or it's the same pathology, etiology?
Right. So, thank you, Dr. Kar. And, the acne in relation to PCOS is, of course, slightly different. Even in adolescence, what we find is that it is more of the inflammatory type. If you see normal pubertal acne, there are more of comedones. It is the milder version in an adolescent age group. But if it is related to PCOS, then one, it would be inflammatory. The distribution of acne would generally be on other areas, including the face, of course, and that is the neck, the chest, and even the upper arms and the back. Now, the acne on the upper arms and the back needs to be differentiated from other conditions as well. And one of the very common conditions is something called as Pityrosporum folliculitis. So we need to differentiate from other conditions, but
Because some people get it more on face and they don't get it on their arms and backs, but some people only get it in their arms and backs. So it's a
arms and
different
back.
condition.
So it depends on, one has to rule out the other differential diagnosis. If it
Okay.
is only on the back and the arms, then one needs to rule out, and typically on the forehead, then
Okay.
Pityrosporum folliculitis needs to be ruled out.
Absolutely.
So acne of PCOS, just to reiterate, is more inflammatory. More of those nodules and pustules will be seen on the face,
Okay.
and it would be difficult to treat with the standard treatments.
Absolutely. So that answers us. So now about these two girls. Yes, sir. Dr. Sultan?
You're very lucky because according to the topography of acne, you may differentiate some acne from another one. I don't think so. In my experience, I've never been able to identify a specific cause of acne according to the topography of acne. I saw hundreds of patients with severe acne in the back without any hormonal disorder. So, okay, I trust you, but in my experience, the topography doesn't help about the diagnosis. This is
Yes.
the first. If I make other comment? Can I? If I start, I will never finish.
No, I think then we should move
No,
on
I
to
mean
the topics.
just one important.
Yeah,
Before talking about acne, I'm sorry. There are three siblings, three sisters. The first question is it a genetic disease or not? And first of all, when I see or I manage three or two sisters, three, it doesn't happen very often, but two
correct.
sisters with PCOS, the first thing should be to eliminate the genetic cause of hyperandrogenism.
Correct.
You agree
We'll,
with
we'll,
me?
yeah,
And the genetic cause, the main genetic cause of hyperandrogenism is late onset CH.
okay.
Before talking about topography and so on, and first of all, is it's a genetic disease or not? And among the genetic, the first, according to the
Correct. So now
is
my next,
CH. So I think, I'm sorry, as a clinician also, you have to eliminate and to clarify the first step is a genetic form of hirsutism.
correct. So
Or,
what tests
acne,
would we want
acne.
to do, sir? What tests would you want? Let's go on with the next part. So what in these two girls, what are the tests that we would want to do? Dr. Sultan, you can answer this. I mean, what investigations would you advise to these girls? Just, I mean, enumerating
Very.
as to what
The
investigations you
first,
all advise.
the first thing, is there any biochemical evidence of hyperandrogenism?
So what tests?
Plasma T first. Is the plasma testosterone
Okay.
to be sure that there is some degree, and this is a consensus,
Total testosterone?
total testosterone
Okay.
all over the world,
Okay.
a plasma T in adolescents above 50 to 55 nanogram per DL
Okay.
is a sign of evidence of hyperandrogenism.
What other
One.
tests would you want to advise her?
And the second one should be the basal value of 70 hydroxy P.
Okay.
70 hydroxy progesterone. Two options. It's normal or it's elevated. In this case, especially familial case of hyperandrogenism, I will perform systematically a synactin stimulation test to find out whether 70 hydroxy P increase above 1,000, 1,500.
Okay. So these are the
Definitely,
two
there
main
is
tests you would want to do. Yes, Madhuri?
Yeah, I would like to say that
Now, my first question would be, would you investigate both the sisters in a similar manner?
no, it will be in a different manner because
Yeah.
the one who has acne, we definitely know that she has hypoandrogenism clinically and she does not require a biochemical test. But the other one who has insulin resistance, probably we know that it is because of hyperinsulinemia.
So just
and
enumerate the tests that you will do because we want to give a
Yeah. So
take
in
home
this,
message for
yeah.
the
So
audience.
in this patient,
What are the
then
tests?
I would like to do a glucose tolerance test. I would do a
Okay.
lipid profile, and in this patient, I would do a testosterone level and more so a pre-androgen index to
Okay.
see whether she has hypoandrogenemia along with insulin resistance.
Okay, so I'll get back to the others to get your opinion. But would you agree with the panelists? These are the tests I ordered, and I thought that both should be investigated in a similar manner. You feel different, but I did these many tests for the two of them. Do you agree or do you differ? If you differ, you can tell.
No, the abdominal
Dr. Menon?
scan in the one who's 21 can be done, and the one who's 17, depending on when she's got her menarche, I would decide because probably we have to wait because you can have a polycystic morphology if she's just had a menarche at 15 and we are seeing her at 17. So it takes
Okay.
time for the polycystic morphology to disappear. So I would not do an ultrasound, but I would do, as I said, we can do a thyroid function test because one of the causes of PCOS like morphology is
No, but so you agree
hypothyroidism.
with all of them. Anything more you want to
Yeah.
add?
Uh,
Dr. Sultan said he would like to add 17 hydroxy progesterone and
If,
also the ACTH activation test. I think he said
yeah,
that.
but if you have features which are suggestive of an
No, that's
adrenal
fine. Is
cause,
there anything
then
you would want to add to this? No.
in a few cases, I
Dr.
would do
Menon?
17 hydroxyprogesterone.
Dr. Menon, would you do any other test?
Instead of doing 75 grams test, there are two things which you can do. One is ask for family history of diabetes. If there's absolutely no family history of
There is a
diabetes,
family history.
yes, That is one point.
Okay.
Secondly, the simplest test to do is hemoglobin A1C and fasting sugar.
Which one?
If the hemoglobin A1C and fasting sugar. The hemoglobin
Okay.
A1C in a
So instead
person
of
who has no
75
symptoms.
hydroxy, you feel you would do a HbA1c and
No, no, no,
fast.
no. 17 alpha hydroxyprogesterone is different. I'm
No,
talking
no, I
about
was
the
saying instead of the 75
75
gram
grams
2 hour,
glucose. Yes.
you would
Yes.
prefer to do a HbA1c and
HbA1C and fasting
okay,
sugar
okay.
is quite
Actually,
sufficient.
HbA1c, according to me, should be done to see whether there's control,
Yeah,
if
then
at all
we'll
there
get
is
back to the
impact. But
recommendations
I
a
don't
little
think that
later.
is one of the
No, no, that
Perfect.
is recommended for diagnosis also
Dr.
by
PC
ADA and other.
Mahapatra, would you
Now,
add anything? Would
now
you add any other test, or you agree with
in
this?
reference to sultans particularly, when three sisters are having that, you point something to the genetic background. That's all right. But I differ from sultan that PCOD is a heterogeneous condition. But adult onset congenital adrenal hyperplasia is not a heterogeneous condition. The presentations are all same. So if you think that similar features are there with the three sisters, then the point of diagnosis will be CAH, not of PCOD.
They are presenting differently.
So from clinical angle, I completely exclude CAH in that particular case because it's never heterogeneous, number one. Number two is that when CAH is there, then it's a must to do the 17 hydroxyketosteroid or progesterone for that also. This is a diagnostic thing for that. Regarding this test which you are advising,
Do you
75, why?
agree with these tests, or you
I
would
don't
want to
agree
add?
with one. I don't agree with one test. 75 grams 2-hour GCT.
Okay.
That is only for obstetric cases.
What would you want to do?
75 grams is never for gynecological. It's 100 gram or either OGTT. OGTT 100 gram is the recommended thing.
But the
It's
current
not,
international guidelines and all guidelines say
yeah,
75 gram GTP.
5 grams is only related to the obstetric part, not for the gynecological part, not for the common non-pregnant state.
Okay,
part.
I'll show, sir,
Yeah.
but it is, I
Yeah.
think 75. We'll get to that. Okay, so that was about investigations. Now, the second thing is what tests for hyperandrogenemia? So, what test would you advise for clinical biochemical hyper? Just quickly, one test or whatever tests.
Now, what are the androgens in the body? I think he has clarified that. The testosterone, total and free, then the androstenedione, dehydroepiandrosterone. So these are the 4 testosterone.
Okay.
If a dehydroandrosterone is there, you can say that 100% is there from the adrenal source, it's never from the ovarian. That's a clear for that. And basically testosterone, free testosterone is needed when there is a the androgenic impact on the skin, acne or hirsutism or virilization. Free testosterone is more important than the total testosterone. That one must be very clear about it. But the fallacy is that we are doing the all hormones investigations by the RIA or ELISA method.
Yes, sir.
These are not an accurate
Yeah.
method for estimation.
Absolutely.
That's from the beginning I'm
Absolutely.
telling.
So we are-
The only accurate method is a tender mass spectrophotometry or mass equilibrium assays. If that is there, then it is justified for that.
Sir, but we still need to manage our patient.
Yeah.
So if we have to
It
give
gives
a
an indirect-
take home message
Yeah.
out of these tests, what do you normally prescribe in your outpatient? We are not discussing today basic science much or the reasons. Sir, I'll get back to you.
I was earlier advising all these androstenedione.
Now what do you advise?
Testosterone.
I advise total testosterone. Madhuri,
Testosterone.
let's get one by one and
But
give
also
your
like
choice.
to do sex hormone binding globulin, because
Okay.
if it is low, we know that the free androgen are much
Okay,
higher.
Dr. Padmavati,
One testosterone level is sufficient, and if clinically
do you
so
do a
obvious
total
that-
testosterone or a free
Yes,
testosterone?
total testosterone.
Okay.
Because that test
Gulrez?
is much more sensitive and specific than free
Yes.
testosterone. Total testosterone.
Dr. Sultan, I mean, you may be because I think you people have much more resources, so maybe prescribing a lot of tests. Is that true?
Can we talk frankly?
Yes.
Okay. I don't think that the question should be raised as this. Which test for hyperandrogenism? As a clinician, you should mention which kind of hyperandrogenism. There is, in the adolescent, at least 3 conditions where you met androgenism.
Sir, but we are discussing these cases. So, in context with these
but
cases,
I follow you.
Yeah.
For these cases, but I mean, for young investigator, for young doctor, they should know that there is different expression of hyperandrogenism, and the investigation should be adapted according to the clinical situation. I'm sorry. And this is, as a teacher, I'm still a teacher, professor. I mean, you have some prepubertal hyperandrogenism which increase during puberty. You have slowly progressive hyperandrogenism. You have explosive hyperandrogenism. You have isolated acne or acne and hirsutism. So according to the clinical situation, so now I come back to your
So
question.
this clinical
This
situation, yes.
clinical, I will ask for firstly total plasma T
Okay.
and 70
Yes,
hydroxy
that
P.
you mentioned.
And if I may just add one comment, what is the mother phenotype? Does she have clinical evidence of hyperandrogenism? Did she have some difficulty to have children? Does she have any evidence of hyperandrogenism? And this is important to make to orient the, the biological investigation. Do you follow me?
Yes.
Because this is a
But I
crucial
have not seen the mother.
information.
The elder sister got them all, so I have not seen the mother.
But you understand my question?
Yes, absolutely.
I mean, according to the phenotype, you should mention she may have 70 hydrox late onset or maybe a PCOS by herself, because in my experience, we had 1/3 of adolescent PCOS were familial, mother to daughter transmission. So I think it could be helpful before starting the biological investigation. If I may.
So, yeah. Dr. Sandhya, what
I think
is
my
there?
opinion is that a
Yeah.
clinical, I think biochemical don't give much more importance to the biochemical. If a clinical will guide us which biochemical
No, sir, but
investigation should be there.
sometimes we have to
See,
document
that because
biochemical
what I say,
hyperandrogenemia.
hyperandrogenism
Yeah.
has a three spectrum of starting from acne, hirsutism, virilization. So if the virilization is there, I think it's more important to describe all the hormones for that
No,
to find
sir,
out the
let's
source.
say the obese girl,
Yeah.
PCO, we need to, if you have to make a diagnosis of PCOS,
Yeah.
and she doesn't have a very overt clinical
Absolutely.
feature,
That's
so
why
you may have to do
for
that
Rotterdam
is the-
criteria,
Yeah.
hyperandrogenemia or clinical hyperandrogenism. That
Yeah,
is there.
yeah,
So if
yeah.
there is a clinical hyperandrogenism, don't give much more importance to this.
Yeah,
If there is
right.
nothing to stamp it as a case of PCOD, then you can say
Yeah,
hyperandrogenism.
exactly. So let's move
Can
on.
I make one
Let's
small
move on.
comment
Okay.
here?
Yeah.
Where it sometimes you have three, so I don't have a problem. But one patient comes to you and there is hirsutism and there is no family history of PCOS and other things, then I may do testosterone. I also want to rule out that over a period of time
Yeah.
it becomes worse. I want to rule out an
Yeah,
adrenal
yeah.
tumor
But
or
we are
other
discussing
causes.
this case, so let's, Dr. Sandhya, I didn't ask you, which of these tests would you want to order?
Total
Just question.
testosterone.
Total. Okay. So the recommendation, the recent international guidelines also suggest that we have what Dr. PC Mahapatra said all about the test, but let's not go there. Yes, we have very limited resources, but you still have to get the job done. So even with limited resources, I would say, would you agree with me or not that just doing the total testosterone and having your own, cutoff points in your center or in your population or whatever the guideline, the reference ranges that your lab gives, you have to depend on that and maybe just do a total testosterone. That may be the best option for these cases. Now, for the lean patient, the 17 and the overweight, these are the reports of the tests that I did. They don't appear to be very different. Total testosterone in the lean one is 91, in that one is around 68. This one has mildly raised glucose intolerance a little more, and the other one is almost normal, ovarian volumes and all that. So there's not much difference between the two where the investigations that we did are concerned. Now, how to manage this? How will you, for example, manage the overweight girl who really has no major complaints? She has menses once in 3 or 4 months and she has very scanty menses, but she has, a significant uh,
Acanthosis.
acanthosis.
So
And
we just advise a lifestyle modification and weight reduction, and we tell her to come back and see us after 3 months. If she is not able to reduce her weight, we can then probably add metformin to her and because she doesn't have impaired glucose tolerance at present.
So
And
you would want to first advise lifestyle, then
yes,
add metformin.
yes.
Okay. Anybody who differs would want to advise metformin from the beginning.
No, I would advise the same weight reduction, but then it is easier said than done. I
Yeah,
have
we'll
seen
not
a lot
go.
of.
We'll not discuss about
But
lifestyle
then
and.
I tell them to come back, and
Okay.
I tell them that we will start treatment. I give them something like a some incentive to lose
Okay.
the weight, and then
Okay.
I see to it that they come back in some time with at least 5% reduction in
Okay,
weight.
Dr. Menon, would you differ and want to add any drug for the obese PCO? Would you like to add metformin? I know that the endocrinologists they like
Very
to add.
often
Yes.
I use it sort of placebo. You
Yes.
see, if
In
you
this,
add
we'll talk in
metformin,
context of this
they
patient.
feel that something is being added.
Yeah.
And then I say that metformin will only work if you also do diet and exercise.
Okay. So
it works
you would
wonderfully, otherwise it may not work. So well.
absolutely.
Sometimes I do
Sir,
that
Dr.
to get
PC
them
sir,
to do.
about the lean. I think this one most will agree. I don't know about Dr. Sultan whether he will agree or not. About the obese one, sir, do you think you would want to do anything other than these? You don't agree with any of these forms of management.
Difficult to answer this question.
Okay, but then the patient is sitting in front of you. She is showing you these particular clinical presentations and that particular list of biochemical tests that you offered. But of course, we haven't done the 17 hydroxy, so maybe we can skip it. Let's presume that that was normal. Lifestyle, okay.
Lifestyle I would advise, and also maybe this is the candidate who must go as first line of therapy OC pills.
You want to add OC pills?
If her periods are not regular, yes.
She is
I
not
would-
regular. She gets once in 3-4 months.
Yes. What is her age? Sorry. I missed.
21.
20. Yes. Here I would like to add.
You would like to add OC pills. She is not okay. Dr. PC sir, you have to say whether you agree with this or would you want to add something for her to get her menses?
If the menstrual cycle is irregular, I will regularize
No,
the
sir,
cycle.
she has irregular menses once in 3-4 months.
So I
But
will
she gets
advise.
very scanty.
I will regularize the menses.
Do you
but
think metformin is not going to give some kind? Because
No,
very
no,
often
no.
metformin gives.
no,
there are
it's not
some-
always. It's not always.
So
metformin.
would you want to add a OC pill or would you want to add a progesterone withdrawal every 2
Now,
months?
I will counsel that because there are
What
two.
would you do between the two?
options are two. Options are two. We need a progesterone withdrawal because we don't want an unopposed estrogen for a long time.
Mm-hmm.
So this is mainly done either by progesterone every 3 months. We'll give a medroxyprogesterone and withdrawal, or have a cyclic bleeding every month. But Indian context, my patients they cannot accept 3 months bleeding. Majority of my patients they want every month the bleeding. So the preferred treatment will be a cyclic OCP in all my cases.
Okay. So
If
for
the
this
patient
also
are
you
convinced,
would want
if the
to
patient
add.
is very happy that I'm happy with 3 months, my first choice will be progesterone withdrawal in that case.
Okay, so for OC pill, if I may put in my opinion also, in this patient, I would certainly advise lifestyle and add metformin at the same time and ask her to come back with her menstrual calendar. I see many people who get at least 8 or 9 menses a month. So let's now get on to the lean because we also need
One
we
comment.
finished one already. Let's get on to the
Always
next.
Even metformin can be added to that because thin
For
or
whom?
lean insulin resistance can be managed by
No,
metformin.
but we've already talked about metformin. So the lean 17-year-old. Now this is a more difficult patient to manage, but she needs to have her menses corrected. So for her, I think all of you will agree about putting her onto OC pill. She
Why?
gets menses every 2-3 months, and whenever she gets menses, she doesn't stop. She gets, she stops 20-30 days. She has bleeding.
Yeah.
And we will not spend too much time on abnormal uterine bleeding because the next
No,
session
OCP
is.
is the drug of choice. There is not a controversy.
Would
about
you
it.
add
But,
metformin?
yeah, metformin is doubt because lean.
Would you have a combination?
Metformin in lean PCOS, I think lean, what is the lean? Externally they may be normal, but the internal intrinsic visceral fat is more. So to counteract the possibility of hyperinsulinemia in those cases, metformin, some people advise metformin for that. But in my preference, I will restrict it to the obese, not the lean PCOS. For
So you wouldn't add a combination?
No, yeah, because her OGT is also normal, so I don't
Yes.
think she will require. And
Any
she does
one
not
of you
have
would
any
want to add a
signs of-
metformin and OC pill both?
If OGT is abnormal or there is a family history of diabetic mellitus, I will aid it.
has acanthosis. So that
Okay,
will
not
growing
not
insulin
many of you
resistance.
agree with that. Okay, is there a choice of combination? Just quickly, any choice or anything is fine?
I think the fourth generation of progesterone combination will be much better.
Gestodine,
It's a,
this,
no, not desogestrel.
then
Not desogestrel. It's a
drosperinone,
drosperinone or
drosperinone.
yeah.
Drosperinone combinations are very expensive.
But that is in comparison to the drosperinone and other generation of progesterone. I
Okay.
think the weight
So
weight
since
loss, weight is a major factor. Anti-androgens factors are there. Anti-mineralocorticoid activities are there. So there's some major advantages of that.
okay,
So
and quickly
just,
let's
wanted
move
to-
on because
No,
we
but
can't.
I think she should discuss on that because she has this patient, 17 years, she has acne and hirsutism, and
Right.
therefore it's important to have a combination
Okay,
OCP
okay,
which
yeah.
has
So
anti-androgens.
just tell us the
in it.
choice. Just tell us because the next session has this.
So ideally, if
Just
the
tell us
progesterone
the combination
is,
that you would want.
which has anti-androgenic activity.
Which one is that?
As a dermat, we would prefer that because with the other OC pills,
So
there
tell us the
is
combination.
breakout. Yeah,
Tell us the combination.
Either drosperinone or ciproterone.
Okay, now the international guidelines. Sir, we should move on, please.
Before that, I think the standard rule of thumb is that if hyperandrogenemia is the clinical hyperandrogenemia, up till acne, drosperinone. Beyond acne, if it is hirsutism, I think drosperinone is also not suitable. It's good for cypertron acetate.
So the recent recommendation of the international guidelines, which is the current most quoted guidelines, tell us that there is no difference. At least there are no studies to show us the difference between the two combination. As long as it is a low dose combination, the differences in progesterone do not show any differences in the clinical outcome. Hang on, I'm just showing you the evidence. I'm showing you the evidence and the guidelines that are recommended most recently. The most important thing is that cyproterone acetate preparations should not be considered first line in PCOS.
So this
is the international guideline that I have taken.
International, they focus that because of the venous thromboembolism, cypertron long term is not to be indicated.
No, these are, sir, just the guidelines.
These are all,
I am not for it. We've been prescribing it for a long time. I'm saying this is what it says because cyproterone acetate combinations are banned in many countries.
No, that is.
So what is the reason? It has. I don't want to go in there. Let's not go. Hepatic toxicity, exactly. So that's fine, but it seems where the point of reducing hyperandrogenism is concerned, all preparations act in a similar manner, and there is not much difference in them. Metformin may be considered. Let's get on because our next is on that. Okay, how long? I think again, let us not go there because I just want to ask you one question. For the 17-year-old girl, can I just write oral contraceptive pill of my choice and give it for her 5 years, 10 years? Yes or no?
I just wanted to mention the onset of action as far as acne is concerned. It is around 3 months, but we recommend that it be continued for 6 months. And as far as hirsutism is concerned, the onset of action is much beyond 6 to 9 months.
No, we are talking about the menstrual abnormality. Yeah, so in this patient, when you're practically dealing, many of us have that question. How long can we give it to her? Any one of you, please answer.
Every gynecologist.
Because if we prescribe for 6 months, she'll have perfect menses, and when we stop,
when
she'll
we
go
stop
back.
it, then again the reversal will be there. That's a very important. And that's
so I'm not covering all this because it is being covered.
But long term use, there is a hesitation of the patients as well as the gynecologist also, because of the myth that long term can create a problem for them.
But then how are you going to control her symptoms?
Yeah, that's what I say, that yes, long term there is no objection for that also. I give for a long term period. There is not a problem.
Okay. So I guess
also depends upon, it helps the other signs also. Long term, that acne and other things are also helped. So
yes, but the safety of long-term use of oral contraceptive pills in a 17-year-old girl who hasn't attained her bone mass and she's PCOS, so she's at high risk for cardiometabolic risks in the long term, because for OC pills we know that it is for contraception, it's been used for 10 years, 15 years. But I guess the next session is going to cover this issue. So this was about long term. So I think most of you do not prescribe for long term. I would like to also take Dr. Sultan's opinion. How long will you prescribe, sir, to a 17-year-old girl?
I mean, from a pathophysiological point of view, as well as for knowing all the side effects of metformin, I used to prescribe this, whatever, alone or in combination, for 1 year. And after 1 year, I stop the treatment and I reevaluate the patient. In 10, as I mentioned yesterday, in 10 to 15 of our cases, we were surprised to observe a complete regression of the symptom. But in 85% of them, we had to prolong for 1, 2, 3, or 4 years. And unfortunately, after when they're above 18 to 19, these patients are managed by adult gynecologists or mainly by adult endocrinologists. But if we do consider that PCOS is a genetic disease, I don't see why we should stop the treatment after 1 or 2 years. It's a long-term management till the adult and
Is
so
the
on.
key. So I think the take home
From
message
a
would be
pathophys-
that you have to keep calling back the patient and keep re-evaluating and keep changing your views and options for that patient if necessary. Now this is another case. Just 14 years, very early teen, mother is 39, she is fertile, BMI is 29, she's diabetic, she has normal cycles. Look at the difference between the two. And the daughter is 14, menarche at 10th year. She has severe acanthosis. And she has severe oligoaminuria. She gets once in a year or once in 6 months or, mostly withdrawal. She has a BMI of 34.8 at the age of 14. She has mild acne, hirsutism, maybe a modified FG score is around 16. Severe acanthosis like it is shown in this picture. Now, I have very specific questions. So, just yes or no. First, will you initiate investigation in the 14-year-old girl? Investigation. Yes or no? Yes? All of you, yes?
If there is acanthosis, the clinical sign itself can be an indicator of hyperinsulinemia and insulin resistance.
No. Question is whether you will initiate investigations for this
I would
case.
only check whether there is diabetes. Rest of them are very
Rest of them are
obvious.
fine. Dr. Sir, PC Mahapatra sir, will you initiate in any investigation?
Blood sugar is a must for that.
Okay, so you will do just...
Don't do sophisticated investigations. Extensive.
Okay. Madhuri, what test would you want to do for this patient? Just
I would-
remember she's only
I
14
would
years
do
old.
a OGTT and I would do a lipid profile for her. And the others are evident.
Would you not do a thyroid prolactin, just routine test, an ultrasound, a thyroid prolactin and all?
I mean, in a teenage adolescent, actually ultrasound does not have any role. Because
Okay,
you
but you'll
basically-
still see it for the ovarian volume.
Yeah, we can see for
And
the
you can
ovarian
also-
volume, though the number of follicles does not have a role. But what they
Because
have said
now
is
we
it's
see
best
PCOS
to-
so early.
I mean, they advise an ultrasound only if you don't have insulin resistance and hypoandrogenemia
Okay.
to diagnose an adolescent PCOS. But when both the features are present, because she has acne, she has hirsutism, and she has in a acanthosis nigrans, so she has insulin resistance.
Okay. So since I do a lot of work in a research setting.
Thyroid, I follow that.
Yes,
Thyroid,
yes.
thyroid,
Thyroid,
prolactin, these are the essential and
So I
pelvis
did
scan
the
and
regular
ultrasound.
tests that I do
But
for
not,
all PCOS.
not all sophisticated anti-androgen investigations I
No,
don't
no,
advise
no.
for.
That we already decided
Yeah,
in our
yeah.
first case. That is
Yeah.
the basic standard test that we'll do is
But
only
these
total
are
testosterone.
routine. These are routine. I agree with that.
Yes. So total testosterone is just about 49. Her thyroid was a little high. Rest everything was okay. In fact, her blood sugar fasting and glucose tolerance test is normal. Now for management, since we have very less time, I have very simple question. Will you, this is her blood work. Will you manage only lifestyle for a 14-year-old girl? Or would you put her on any medication, if any? Addictions are starting so early in life, sir. How to induce
I would-
lifestyle changes?
I would repeat the thyroid function test, that is TSH, with anti-TPO antibody.
So
If
we
they
will
are
at
both
least
positive-
give a thyroid supplement. Perfect.
No, if that is high, TPO is positive, then yes, you have to give thyroid.
With 7.8 also you will not
You
give
don't. Only the recommendation is to start treatment
Okay,
about 10.
okay.
So there is plus minus. Some people do give it for 1 year and see whether it helps or no.
That's
but
fine.
generally,
So
TPO
only lifestyle or any medication? This is my question.
and lifestyle.
I think 34 BMI.
Yes.
There are three modalities of PCOS in this case.
Okay.
First modality is weight loss. Second modality is weight loss. Third modality is weight loss.
Okay. So only lifestyle. Perfect. Madhuri, you want to add anybody who wants to add a medication, then tell me. Other than thyroid.
Certain newer drugs coming up like lorcaserin.
No, but this patient, madam, in this particular
I would
patient.
not like to start without lifestyle of at least 3 to 6 months.
Okay, perfect. So we only advise lifestyle because I feel I would do that. So Gulrej, this is for you. Do you think you can do something about her horrible looking acanthosis?
So, you know, there are.
Or do you think it will go if she loses weight?
So, acanthosis, the only treatment, US FDA approved treatment is metformin, and with lifestyle changes and weight loss, it definitely reduces. But in the interim period to take the patient through, we do a lot of treatments. We do peels, we advise certain applications.
So some local cosmetic treatment.
Local cosmetic treatment may just
Okay.
help her along. But the treatment is metformin and weight loss.
Okay, so 1 minute, I didn't get you, sorry. So would in this patient you would want to add a metformin?
So maybe, I mean, you know.
No, would you or would you not?
If the lifestyle changes fail and if she's unable to,
Lifestyle,
bring about
okay.
weight loss, then definitely add metformin.
Okay, okay.
I would
So-
just add one
yeah.
small thing. She could be having an eating disorder. She could be eating absolutely wrong, definitely with so much of. I would like her to have a little bit of psychological counseling. In this
I'm
patient.
so happy you brought this up. I'm so happy you brought this up. So, okay, so the last case, and we finish in 2-3 minutes. Now, this one is a 21-year-old girl. This is her mother, and this is her. She has severe oligoamenorrhea, morbid obesity with a BMI of 46.7, and she's significantly hirsute, acne, and all that. This is her abdominal. She has severe skin stria all over. She has significant hair loss, frontal male pattern. She has a very strong family history of everything: diabetes, hypertension, hypercholesteremia, obesity, everything. Now, this is the question where I want to ask. Other than the routine, in this kind of patient, would you ask for tests which tell you about Cushing's, CAH?
I would
etc.,
like to
etc.?
rule out Cushing.
What are the tests, madam? Just enumerate the tests.
Only one test is
What is that?
necessary at this stage, overnight dexamethasone suppression test. 11 p.m. you give her a 1 milligram of dexamethasone and do the early morning 8 a.m. cortisol. If it is suppressed, Cushing is ruled out.
Okay.
Baseline is not required because what you are seeing is whatever the baseline, is it getting suppressed on dexamethasone? If it is getting suppressed on dexamethasone, Cushing is out of the window.
Yes, sir. You will do, yeah. So I thought the serum total cortisol was the important test. No?
Not necessary at all because it can be 20, it can be 30, but you give dexamethasone
What?
and it goes minus less than 2, your this thing is
1
reached.
minute, 1
You
minute,
don't
1 minute,
need
Madhuri, 1 minute. Dr.
The
Menon, yes, 1 minute. So you'll do the dexamethasone suppression test,
It's
and
the
what for the
diagnostic.
CAH will
1
you do
minute.
the
I
17?
just want to clarify.
Yeah.
It is the diagnostic criteria that if it is less than 2 or 1.8, it
Okay.
rules out Cushing. This is the diagnostic test for Cushing.
Okay. And what about CAH? 17 hydroxy, these two you will do or anything else?
CAH, maybe I would think I would examine her, especially the
I've shown you
vaginal
all the
opening,
features.
whether clitoromagaly is present. I would certainly do.
So
a
you will do
CAH.
only if there is severe virilization, features of severe virilization, not in this patient. Anybody wants to add any tests?
Because
Other
here
than
with
tests
that
for
alopecia and all those things, you do want to rule out an adrenal cause.
anybody wants to? That, yes, that we have established. So you would want to do. Okay. So, okay, now all her tests are normal. Thyroid is little high. Total testosterone is 78. Her glucose is very high. All her lipids are abnormal. I did total serum cortisol. I should think about the suppression. That's fine.
It
That
doesn't
was-
rule out Cushing. It doesn't.
Absolutely. That was normal. Hydroxyprogesterone was normal. Scan was normal. Ovarian volume was, of course, very high. So the diagnosis would be PCOS. Now, in this patient, 46, lifestyle we will not discuss. It's not going to be easy. My question only is there a role for bariatric or anti-obesity drugs? That's all.
Both have roles. You could start with a
No, in this particular patient, what would you first advise as an endocrinologist to
as
help
an,
her
as
help
an
her lose weight?
endocrinologist, always weight reduction, lifestyle modification. That is first on my line.
No, no, no,
And
madam, 1 minute. How will you help her in attaining her lifestyle or weight reduction? Will you advise her anti-obesity drug? If yes, which one?
the anti-obesity drugs so far available doesn't do better than lifestyle, and they have side effects.
But
The
lifestyle is
only
so
now
difficult.
one
People have
minute.
such
Only
abnormal.
one thing which has come up is lorcaserin, which is going to be introduced into
Which
Indian
one?
market. Lorcaserin.
Okay.
All of them have side effects. All
Okay.
of them, the Western world is very unhappy about the anti-obesity drugs
I have a
in
nice
general.
video for the audience to
If
show
you
how lifestyle just doesn't work and people have very abnormal
Yes,
expectations.
lifestyle works, but it takes a long time.
Yes.
Let us understand that obesity is a problem where you are fighting with your genes and your body.
Yeah.
Body doesn't want to lose weight.
Perfect. Okay. Yes. Excellent.
So, what I was trying to say
Yeah,
is
that's
that somebody with
incredible.
a 46
Lovely. Yep.
BMI
Leave
needs
camera
help.
now. Spot on,
You
Emma.
can't say
Great.
go
Yep.
do
Down
something.
the barrel.
So you have to give her
Okay.
some practical advice.
Got it?
I mean,
Right.
should she join a gym? Should she take an anti-obesity drug? What should she do?
There is one more drug which is in the market, GLP-1 agonist for obesity. If they make an appearance, it would be a very good choice because and the second choice, or in this case, the best
Is she
choice
a candidate
would be,
for bariatric?
yes, she is.
Okay. Anybody who wants to say anything different than what Dr. Menon said?
I think bariatrics would be a last resort for that.
Sir, what would you do for
It's
her?
not a first. I think again counseling acts very much for that.
No,
I
sir.
think,
46, it's nothing's
I
going to
think
work.
I think
You have to give her a more concrete help. You can tell her, go join the gym, go join VLCC, go do this, go do that.
See,
something,
there are
or take a dietitian, or something.
I think diet is the first thing. Diet and exercise were initially a lot of importance was given on exercise. Now I think diet is much more important than the exercise.
So you'll just get rid of her.
I feel it's easy to tell but difficult to practice.
Yeah.
But counseling, I will say that the only
Will
best,
you
the
connect
best
her
counselor,
to a psychologist for
the best
abnormal
counselor
eating
of
patterns?
her is not the mother, not the doctor. It is the boyfriend. If
Who?
the boyfriend counsels, she will go to that.
So
See,
you
have
will
a boyfriend
ask her to
because
go
she is
get a
46.
boyfriend.
these,
Yes,
I just like
No,
to-
one more thing, you could add temporary measures. There are, gastric banding and so many other things. Give her an incentive for some amount of weight loss and then say go back to the dieting. So gastric banding is a reversible procedure. So there are different types of procedures and you could take
Okay.
help.
So
And the
if I
newest procedure is eroding the gastric mucosa by hot water scalding. That's a newer method.
Okay,
which
so
we
I
start-
think the take home message, and we have to finish now, to the audience would be for a patient like this. Not all my panelists are agreeing on one particular thing. I think the endocrinologist in us is agreeing for a bariatric surgery. Others, I think Sandhya would want
Yes.
her to have a counselor.
yes.
At least something, because you just tell her, go, don't eat, don't work out. She's not going to lose weight. Dr. PC says not going to, he's just going to get rid of her. Go do your own thing, lose weight, and come back to me. Counselor. And not many takers for bariatric, but I would think she's a candidate for bariatric.
She is a
Because she has
candidate.
such a
One more
strong
comment.
family history. She is going, and she's already glucose intolerant. Although the guidelines for bariatric surgery tell us that if you have one comorbidity and a BMI more than 40, you may consider bariatric.